to move on to Dr. Wohler. He's spending his last few months on the tumor service, so he was kind enough to give us a tumor topic, and we'll turn it over to Andrew.
Yeah, like Dr. Pat said, we'll have a little bit of a change of pace here. I'm Andrew Wohler. For those of you that haven't had the opportunity to work with me over my 5 years here, I'm one of the PGY5s. I'll be presenting on presentation management, Sequela of childhood leukemia, kind of a brief primer for the orthopedic surgeon. I have no financial disclosures to report related to this topic. However, I think many of you know my wife does work with the Peds Hem-Onc team, and she has been kind of some of the driver for choosing this as a topic, as well as some patients that we've had come across our service the past few months. Brief outline of what we'll be covering today, and then kind of want to dive into a case. This is a 4-year-old female. She presented initially as a transfer from an outside hospital. Parents gave history that she'd slipped and fallen 2 months prior to presentation and began complaining of back pain. Had another fall kind of 2 weeks prior to going to the hospital. Again, still complaining of back pain. Pain had been manageable with anti-inflammatories until 48 hours prior to presentation, at which point she had a sharp increase in her pain and a refusal to walk or crawl, and parents ultimately sought care at that point. Past medical history was significant for an autism spectrum disorder. The exam that was documented in her notes reported that she's in no acute distress, very comfortable, no masses or lymphadenopathy in her neck. Her abdomen was soft without hepatosplenomegaly. In terms of her musculoskeletal exam, she was mildly tender over the iliac crest with some minimal tenderness in the lumbar spine, had pain with movement of her legs, but otherwise relatively non-specific exam. MRI of her CT and L spine were obtained given kind of her history and transfer from an outside hospital that showed multiple thoracic, lumbar, as well as a sacral compression fracture. She did have some labs that had been obtained from the outside hospital that are available for review here. They were a little hard to find in the chart as they had been scanned in. Overall, you note kind of relatively normal cell counts within her major lineages, with a slight imbalance in her differential and some mildly elevated inflammatory markers. Ultimately, orthopedics was consulted, imaging was reviewed, subacute S3 fracture. Recommendation was for rehab if she had persistent weakness, weight bearing is tolerated without operative intervention. Neurosurgery was also consulted for her multiple thoracic and lumbar compression fractures. They recommended a TLSO for comfort with no operative intervention needed. CHIPS was consulted eventually for discussion of admission given patient's ongoing pain. And after a lengthy stay in the emergency department and discussion with the CHIPS team, ultimately made the decision to go home and follow up with a pediatrician. Obviously, you guys probably know where this is headed based on the title of my talk, but I hope this is sending up some red flags in a young patient with multiple fractures and kind of inability to want to bear weight. Moving into leukemia, kind of back to your USMLE days, 4 major types that are subdivided between acute and chronic, and then based on their lineage, lymphocytic or myeloid. Acute lymphocytic leukemia is the most common leukemia in childhood. It comes from a B or T cell lineage. Acute myeloid would be the second most common, and then chronic myeloid leukemia makes up the small subset of remaining patients. CLL is largely a disease that's reserved for adults. Specifically turning to pediatric leukemia, as I mentioned, ALL is the largest, makes up about 80% of diagnoses. AML is 15 to 20%, and then CML is the remaining 2 to 5%. In the US, there are about 6,000 new cases of ALL diagnosed annually, with half of these occurring in children. Peak incidence is between 3 and 5 years old, with variable incidence by race, African Americans being slightly less affected than Caucasian and Hispanic populations. There are several genetic factors that are associated with increased risk of ALL. The one that is frequently tested is Down syndrome. However, of these genetic factors, the majority are sporadic mutations with no recognized inherited kind of factors that contribute. Turning more to the musculoskeletal presentation, I'll be kind of referencing this study over the next few slides. This is a retrospective review over 15 years of 122 patients that were diagnosed with acute leukemia, kind of chronicling their symptoms at the time of diagnosis. Studies suggest that patients will present with musculoskeletal symptoms between 21 and 59% of the time. The most common symptoms, and what this study found, was about 38% of their patients presented with musculoskeletal symptoms, including pain and functional impairment. Of those other symptoms that are common, there's an extensive list here that I won't belabor reading, but pallor, hepatosplenomegaly, lymphadenopathy, and fever are also common presenting symptoms. Similarly to a high percentage of these kids presenting with musculoskeletal complaints, approximately the same number present with at least some radiographic abnormality at the time of presentation. This study found that 49 of their patients, which was 40%, had at least one radiographic abnormality, including osteolysis, metaphyseal banding, osteopenia, osteosclerosis being the most common findings. This is consistent with data across the literature that suggests this is between 40 and 70%. Interestingly, only 16 patients had symptoms at the site of the radiologic abnormality, whereas many patients had no symptoms with findings on X-ray, or had no findings on X-ray despite symptoms, kind of raising the question of if there is a positive finding, it can be useful, but it may not always occur at the site the patient is complaining at, so limiting some of the utility in initial diagnosis. Quick overview of what these findings look like. Here's radiolucent metaphyseal bands in the distal tibia and proximal fibula. Similarly here in the proximal tibias. Evidence of osteolytic lesions within the distal tibia here on the left and proximal humerus. And then some more permeative patterns that can be typical of more aggressive lesions with mixed kind of osteolytic and osteosclerotic findings in the proximal tibia, radius and ulna in these images. Turning to laboratory findings, obviously a CBC with differential is going to be one of the hallmarks and key elements of making a diagnosis of leukemia. The traditional teaching is that more than one cell line is affected, often with leukocytosis, with normochromic anemia and thrombocytopenia. It is important to note that some patients can present with normal cell counts, as we saw in our case, as well as kind of some of the laboratory values that presented in this retrospective review that I mentioned. While the median numbers are low, the mean numbers for platelets would be within normal limits. However, they did present with anemia. Immature white blood cells, known as blasts, can also be present in the peripheral blood, and this can give a clue to the diagnosis of leukemia. Can be used in isolation to make a diagnosis if blasts are present to a sufficient amount, but typically a bone marrow biopsy is needed for definitive diagnosis. Turning to the white cell counts that patients presented with in this study, you can see 2/3 presented with a white count less than 20,000, which, as anybody who's seen a pediatric patient in the emergency department for rule out of infection, this is going to be right in the range that we typically see with septic arthritis, osteomyelitis, and kind of many of the other conditions we're consulted to evaluate, which I think just lends to keeping this on your differential diagnosis when evaluating these patients. Going back to our first case, ultimately the patient did go and see her pediatrician in follow-up, where a referral to a pediatric hemonc team was initiated with a diagnosis of pre-B-cell ALL. I do want to spend a minute here. You can see some screenshots from Cerner that kind of go over some of these laboratory findings and what you're looking for on this. When you're seeing these patients. I didn't have a whole lot of experience with a differential, and I think that there are some keys that can be gleaned from this. Obviously, you see an absolute neutrophil count at 0. That should raise red flags on its own. But as you scroll further down and you get to areas where it says other, or there's comments on morphology of the cells or comments on platelets, these are spots that you can click and get more expanded information from the chart. The other section is typically what reports atypical cells. And so this is 52% atypical cells, which the machines that automated automatically read these cannot print out a diagnosis of leukemia, but this in and of itself typically is going to be diagnostic for leukemia. When you open the comments, you can see immature cells were present, and that triggers a slide to go for path review. Turning to the management of ALL, in the 1960s, ALL was almost a universally fatal disease with survival rates less than 10%. You can see the dramatic steps that have been taken in terms of treatment and survival of these patients over the last 60 years, with this review article out of the New England Journal of Medicine showing current survival rates up approaching 95%. For patients that are diagnosed with standard risk ALL, again, survival 95+% with up to 98 to 100% for some of the low risk categories. Raising the question, how do we determine risk in these patients? You can see the large prognostic factors would be age, so age less than 10, white cell count less than 50,000, negative central nervous system, negative testicular disease, and then favorable cytogenetics with good response to induction chemotherapy with minimal residual disease less than 0.01 are all kind of favorable prognostic factors. Older patients, higher cell counts, and kind of the opposite of what I mentioned would be higher risk. Brief overview of treatment. I'm not going to list all of these medications, but I think it's important to mention treatment duration lasts 2 or 3 years, and kids are receiving cytotoxic chemotherapy over a long period of time when being treated for leukemia, which obviously is not without some deleterious effects. I do highlight the steroids as they'll become a little bit more important in our talk as we move forward. Again, no good deed goes unpunished. So here are the common medications that are used in treatment of ALL, and you can see osteopenia, osteonecrosis, osteoporosis, as well as secondary malignant neoplasms as common sequelae. Moving on to a second case, it's a 13-year-old female who was referred into clinic with bilateral hip pain. She'd had ALL diagnosed 4 years prior to presentation in the orthopedic clinic. She underwent successful treatment with disease remission. Ultimately, she had chronic pain in her bilateral hips that had been slowly progressive. On her exam, she had a non-antalgic gait and was distally neurovascularly intact, however, had marked limitations in range of motion of her bilateral hips. Here was her presenting radiograph, and you can see AVN of her bilateral hips with subsequent femoral head collapse and changes to the femoral head as well as acetabulum. So of the sequelae, some of the more common and what we'll going to be focusing on in this talk include AVN, osteoporosis. I think this would be incomplete without at least mentioning skeletal growth disruption for patients that have refractory disease and ultimately go on to require bone marrow transplant. They do frequently receive whole body radiation, which can stunt skeletal growth, as well as cognitive and neuropsychological issues from long-term intrathecal chemotherapy, cardiac toxicity associated with anthracyclines, and then secondary malignancy. Taking a little bit deeper dive into AVN, the exact mechanism at AVN remains unknown. Several proposed mechanisms include marrow fat hypertrophy leading to an increase in interosseous pressure and ultimately decrease in blood flow. Others include damaging effects of glucocorticoids on endothelium of nutrient arteries and smooth muscle of nutrient arteries, disrupting blood flow, as well as glucocorticoid accumulation within intracellular environment of osteocytes, ultimately leading to apoptosis. There are several known risk factors that are well published, including older age, greater than 11, female gender, as well as increased cumulative dose of corticosteroids and the strength of the steroids, with dexamethasone being slightly higher risk, as well as patients that are in the high risk ALL category, often because they're receiving more aggressive chemotherapy. Interestingly, with the age, I think one of the proposed mechanisms of the protective effect in younger patients is that the physis kind of spares the femoral head from some of the increased pressure that may be seen within the canal of long bones. Multiple joints are typically affected in these patients, with studies ranging between 1.7 and 3.4 joints affected per patient, and frequently these will be presenting bilaterally. And then the time from diagnosis of leukemia to diagnosis of AVN is on the range of 20 to 30 months. Looking specifically at AVN of the femoral head, we have a subset or separate talk kind of within our clinical didactic curriculum, so I won't belabor this too much, but treatment strategies include bisphosphonates for FECAT 0 to 2 kind of pre-collapse lesions. There are several good studies, a randomized control trial out of JBJS that showed at 2 years, 64% in the control group had gone on to total hip arthroplasty versus 3.3% in the group that received bisphosphonates. Core decompression can also be used for pre-collapse lesions with the thought of stimulating kind of marrow and blood flow to the area. This was used in a study out of core in 2002, FECAT stage 1 to 4 lesions that showed earlier lesions had a much higher success rate, with only 9 of 145 patients going on to total hip arthroplasty at 10 years versus nearly half, 25 of 49 that went on to total hip arthroplasty in FECAT stage 3 and 4 lesions. Additionally, rotational osteotomies can be used for small lesions, so you can redirect the femoral head to improve coverage. Vascularized prefibula transfer has been used in a subset of patients. However, total hip arthroplasty remains the gold standard for collapsed lesions, as well as some of the failure of the other treatment strategies mentioned above. Looking at AVN of the femoral head in the pediatric leukemic population, this was a study that identified patients after treatment, and they found 80 patients, of which over 75% had bilateral femoral head involvement. Median age of diagnosis kind of fits with our risk factors at 14.6 years. They ultimately found that 29% of the patients required an arthroplasty at a median of 1.3 years after diagnosis. Some risk factors were larger femoral head size lesion, greater than 30% of the femoral head, with 80% of these going on to collapse within 2 years of diagnosis, and over half requiring arthroplasty. Which begs the question, when arthroplasty is performed in the young patient, how do they do? This is a recent study out of JBJS that is a retrospective review of 91 total hip arthroplasties performed in 78 patients. The median age at the time of surgery was 17, and they had average 8-year follow-up for these patients. 47% of the surgeries were done for AVN in this population. Ultimately, they had a significant improvement in the Harris hip score with average post-op at 92. 95% of patients reported feeling much better after surgery. 10-year survivorship is also similar to kind of what we expect within the adult population, with reoperation rates at 10 years, or no need for reoperation being 95%, revision-free 97.2%, and then no complication in just under 90%. Of these, the 2 revisions that were performed in this group were performed for aseptic acetabular loosening. They also broke down bearing surfaces and found that ceramic on ceramic, ceramic on poly, and metal on poly all had similar survivorship and clinical outcomes. Kind of switching gears to a different anatomical region. There's less published on this, but I think this was a good study that at least proposed a treatment algorithm, as well as reported some results for a treatment of AVN of the proximal humerus. Their treatment algorithm began with kind of PT and NSAIDs, conservative therapy for mild to moderate pain, with moving on to steroid injection, arthroscopic evaluation with a decision tree for core decompression for intact cartilage, debridement and chondroplasty for cartilage defects less than 2 centimeters, and then debridement with a plan for resurfacing for larger cartilage defects. And then patients that presented initially with advanced collapse, they were kind of funneled into a resurfacing arthroplasty pathway. Ultimately, in their treatment arm, outside of conservative therapy, they did have 11 patients that underwent injection, of which 7 required no further treatment, 12 that received core decompression, and 9 required no further treatment. And then ultimately, 8 shoulders went on to hemiarthroplasty, 3 within the shoulder injection group, 3 within the core decompression group that failed, and then 2 that presented collapse at initial presentation. Their median follow-up at 6.2 years reported improvements in pain, functional impairment, and range of motion across all 3 treatment groups. Turning to osteopenia and osteoporosis, we know that giving high levels of cytotoxic chemotherapy to young patients with developing skeletal systems has detrimental effects. Here are several studies that kind of highlight that. Long-term survivors of childhood cancer fail to reach optimal peak bone mineral density, either because of cancer itself, malnutrition during chemotherapy, or kind of decrease in activity levels. Also, the onset of many of these diseases is during the first and second decades of life, when 43 to about 66% of the adult peak bone mineral density is achieved, leading to a high prevalence of osteopenia and osteoporosis in this group. These studies found that low bone mineral density is more prevalent than expected based on population norms, with 24% having a Z-score less than -1 at a median of 30 years. Ultimately concluding survivors of childhood and adolescent cancer are at risk for osteoporosis during as well as after completion of therapy. This is a screening algorithm that has been proposed for osteopenia. In this patient population, and after discussion with our pediatric hemonc team, this is initiated for patients once they kind of enter their survivorhood treatment. And I think it's important just to note, optimizing calcium and vitamin D in screening is going to be an important part of these patients' care moving forward. It does beg the question, if you kind of remember back to my graph of survival, I think we're probably getting into the age range where we're going to start seeing many of these patients back for osteopenic and osteoporotic fragility fractures as they reach older ages. And some questions probably still remain about what effect that will have. Wrapping up our second case, patient ultimately went on to receive bilateral total hip arthroplasties later that year. She had done well until about 10 years post-op, at which point she was complaining of some noise and pain in her right hip that was thought to be due to the ceramic on ceramic bearing. She ultimately underwent revision and has not had any issues since. Interestingly, she did have evidence of ABN kind of changes within her knees as well as ankles that ultimately have not required any treatment. And she is now 27 and starting a family of her own, lending further evidence towards how far we've come with the overall management of ALL in the past 60 years. Conclusion, I think it's important to maintain a high index of suspicion. Obviously, it's been said, if it's not on your differential, you're never going to make the diagnosis. And just because you haven't seen it doesn't mean that it has not seen you. Order and assess radiographs and labs thoroughly and make sure to look at the differential. If there's anything that I can kind of emphasize for people to take out of this talk, hopefully that is helpful. Obviously, treatments are not without deleterious effects, and it's important to work up and manage some of the complaints of ABN symptomatically, and then if necessary, refer to surgery. And then kind of one of the questions that remains, osteoporosis and osteopenia in this patient population. We expect to see it, but I think the long-term effects of this are still not well known. Here are my references. I'd like to say thank you to Dr. Scannell, Dr. Casey for some guidance on this, as well as Dr. Masson is kind of focusing on some of our discussion for management of hip ABN. Dr. Kaplan and Dr. Hinson are pediatric hematology and oncology colleagues, and obviously my wife who works with them.
Thanks, Andrew. It's a very, very nice review of a topic we don't think a lot about in orthopedics. I think that the biggest point I'd make is to reemphasize the very first line of your conclusion slide about high index of suspicion. So I can tell you from, thinking back to maybe 5 or 6 just egregious misses in childhood cancer diagnoses, or other benign bone tumors, most of the time the issue came down to the very, very basic principle that Dr. Niesel preaches to every resident: history and physical. And you have to make sure that that history makes sense to you. A 4-year-old with multiple level compression fractures, that is a giant red flag waving in front of your face. It doesn't happen without a significant mechanism. And I can tell you, one of the worst cases I saw similar to that was a kid who had a 2-level compression fracture, upper thoracic, was actually treated in Florida, had continued compression at 4-week follow-up and continued pain. So the surgeon took him to the operating room and operated on him and decompressed him. This is like a 12-year-old, so fixation of a spinal injury. And lo and behold, he had Ewing sarcoma of his spine. So again, the mechanism was that he fell down playing soccer. Nothing, didn't even come out of the game. He just fell down. So, make sure that history and physical correlate with things, because that is the number one thing that will keep you out of trouble in your career.
Yeah, I think.
Hey, Andrew. Hey, Brian Brighton. I would just, echo Dr. Pat's comments, but what happens in many of these kids, just like when you're seeing them in the ER and management for, an infection workup, they often give this remote history of trauma, and many of these kids have some little trauma. The family can recall falling off a bike, a trampoline, and so, as you said, be critical of, does the injury fit that mechanism that we're talking about? I think the other thing you had mentioned was sort of the laboratory values, and I always look at the hemoglobin. Is there any associated anemia? Look at the platelets. We're getting a CBC and we're looking at the white count, but as the hemoglobin, hematocrit, and the platelet count do matter. And then lastly, you were talking about I probably have seen kids that had leukemia, but I didn't know that. I've probably only diagnosed a handful of them, but I've probably seen more, just missing it or just catching them early in their disease course. But the other thing you mentioned, which I feel like we see more of now, is these children who have sequelae of their disease and treatment, and whether they're going on to osteonecrosis or some joint collapse from the tumor kill from the leukemic cells, as well as the steroid and AVN. We're seeing a lot more of those kids, and so certainly the hip ones are difficult to manage, but a great summary just to think about. So
yeah, I think from my discussion with the PT Monk team, that's kids don't regularly complain of back pain. So 4-year-old complaining of back pain, or 4-year-old coming in not wanting to walk, just kind of sends up a little bit of should spark some questions, I think.
Andrew John Masanis here. Thanks for the talk and adding in the adult hip stuff side of it. One question for you: is there percentage wise, reviewing the treatments currently now for ALL, what type of percentage did you see for osteonecrosis, particularly femoral head osteonecrosis?
Absolutely. So the ranges kind of ranges based on the risk categories. There was a study out of CHOP that put for patients with high risk ALL, their rates are about 10%. For kind of standard risk and some of the younger patients that are presenting, reports in literature are somewhere between 1% and 4%. So not an insignificant number, obviously quite a bit lower in the standard risk groups. And I think that's probably a combination of younger patients that we know are probably less likely to get AVN to begin with, lower amounts of steroids that are given to those groups compared to the higher risk groups.
Yeah, I think it makes me wonder if there's a subgroup that should actually be screened. Maybe that's by MR screening. And then the other question is, the data that you showed for bisphosphonates and core decompression, many of those are not related to chemotherapy induced osteonecrosis. So it's hard to translate those outcomes, but I wonder in this high groups, if you're looking at something that has an N of 10%, should we be considering a screening MRI in those children once they reach a certain steroid dose or a certain chemotherapy regimen just to see if you can catch us earlier. Because as you pointed out, a lot of times these teenagers show up, and certainly when we see them on our side, obviously things have gone quite a long time without treatment, and so they've progressed to OA of the hip and really don't have a great alternative other than hip arthroplasty. But thanks for the talk. I thought you did a great job.
Yeah, this is Dr. Kaplan from Pete's Oncology. Just to answer your question, in the last COG trial of high-risk ALL, we did a prospective MRI of patients just to get the natural history of this in patients. So that data will be forthcoming in the next couple of years.
Great.
All right. Thank you, Joel, for chiming in and being part of this morning. Thanks to everybody for tuning in, and Alex and Andrew for your talks this morning. So thanks to everybody, and Foot and Ankle Journal Club to follow.